Welcome also to our esteemed panel of experts who I am going to introduce shortly. I'm Michonne Rogers. I'm the Executive Assistant to Mayor Kim Norton. I will be moderating your panel today. Travis Amundsen from the City Clerk's Office will be moderating the submitted questions, and he is also our technology guru if you have any questions or concerns. Today's program is an opportunity to hear from national and our local experts on the state of COVID-19 and particularly the Delta variant, so that we're all hearing the same messages and that we get your important and timely questions answered as well. Today's session will be videotaped and it will be made available for those unable to attend. We will try to get that posted on the city's website this afternoon after the webinar. The format will include brief comments from each of our panelists and your questions will follow. Please enter your questions in the Q&A area, not in the chat area. This is important because we chose this format due to the open meeting law to avoid any discussions that might occur in the chat area. When you use the Q&A area, everyone will see all the questions, but you won't be able to have a dialogue or a discussion with each other. Now to our three distinguished panelists. Director Graham Briggs, he's the Director of Olmsted County Public Health, and he will be providing a local perspective. Dr. Aaron Berbari, an infectious disease specialist from Mayo Clinic, has also joined us, as well as Dr. Joshua Sharfstein, the Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health. Thank you, gentlemen, for your time today and for sharing your important perspectives on this topic. Let's start with Dr. Sharfstein for a brief presentation from a national and global perspective.
Thank you so much, and thanks for having me here. I'm Josh Sharfstein from the School of Public Health at Johns Hopkins. I'm a faculty member in Health Policy and Management and the Vice Dean for Public Health Practice and Community Engagement. Just going to share my screen here for a second, just to give a very brief update. Let's see if I can get this to work. So this shows the global picture in COVID cases. You can see that the United States is this green line, which is now at was for a long time was the highest number of cases in the world. Then India came surging, and the number came way down in India. And then the United States is again the highest number of cases in the world. Nationally, we see that this is the most recent data showing that there is certainly an increase nationally, but we're particularly seeing it in the South. Florida is really off the charts for the most recent changes. But as you know, the Delta variant has brought the number of cases a day way back up, and we're at 100,000 or more. What is a virus variant? The Delta variant is the cause of this. The variant is that the actual genetic code of the virus is changing, and it's particularly changing in the area of the spike protein. And that has meant that the Delta variant is able to more easily get into cells. So you don't need as many particles to get sick. And that makes it much more transmissible. It may also be more lethal, but the evidence on that is not conclusive. What is very conclusive is that it is much more infectious. And that's why when you look, I'm going to go skip ahead one, that it's really outcompeted all the other variants. The Delta variant is this big orange bar, and you can see over time how it's gotten to the point where 90+% of the cases in the United States are now from the Delta variant. It's just very, very quick to transmit. Couple other things is that the immune response to the vaccine is actually pretty strong for the Delta variant. There's only a small decrease in the immune response for people who've been vaccinated. So vaccines work very well against the Delta variant according to data from a few different sources, but natural infection also provides some level of immunity, but since natural infection gives a very natural infection for one person could give immunity that's very different from another person, whereas the vaccine is much more consistent. It's still much more likely that you would get sick after a natural infection compared to the vaccine, which is why the vaccine is recommended for people who've been infected. The number of vaccinated people getting sick with the variant is largely a function of just how many infections there are and the fact that there's a slightly decreased efficacy for the vaccine. For every, if there are 100 people in a population of unvaccinated people getting infected, then if it's the same size population of vaccinated people with the same exposure, maybe there are 5 or 10 people getting infected who are vaccinated. They're much less likely to be severely ill compared to the 100 people. But then if it turns out there's so much virus that there are 1,000 people getting infected, then now it's 50 to 100 people who are vaccinated who are getting infected. So we're going to see more of these breakthrough cases, just the more people who are exposed to the virus. But so far, by and large, people are getting a lot of protection. Even if they are getting sick, they're not getting very sick if they're vaccinated. So what do you do? There is a basic playbook for responding to Delta. Vaccines are the number 1, number 2, and number 3 because of the strong protection the vaccines offer against the Delta variant. Masks are also recommended because of the way that coronavirus is transmitted through aerosols and through droplet spread. Additional mitigation measures in schools are recommended, including not just masking for the students and teachers, but also improvements in ventilation and being careful about extracurricular activities and some others based on the rate of spread. And in general, this is a moment to continue to strengthen public health responses, including basic surveillance testing, support for isolation and quarantine, which can make a difference. I was looking at Olmsted County, you're still relatively low spread. The cases are going up. Your hospital capacity is very stable. This is a moment to, recognize the risk that you're at, but also to take actions to prevent the situation from getting much worse. And I'm aware that you have very high vaccination rate right there in Rochester, but it's also, the case that you may be surrounded by places that aren't that high. And so therefore the virus is still circulating around, and taking a reasonable degree of precautions seems prudent at the moment, given the velocity with which this variant can spread. So I think I'll stop there.
Thank you, Dr. Sharfstein, for that more global national look at what's happening with COVID and the Delta variant. Next, we're going to welcome Dr. Berbari from Mayo Clinic. He is an infectious disease specialist from Mayo Clinic, and he will share a research and treatment perspective here from Mayo Clinic. Thank you.
Thank you, Michonne, and thanks for including me on this symposium. I may want to build a little bit on Dr. Sharfstein's data, and I would say not only vaccine, I'd say vaccinate. We need to transform those vaccines into the arms because we have plenty of them. We just, we want to encourage people and make sure that everybody's on board. So just looking at the landscape and how that has changed over the last 6 weeks, it's amazing to know that early in the summer, the US was experiencing a very low rate, up to 10,000 cases or lower per day. Now we are 100,000 or more. And if we ask ourselves, why is this happening? The answer is a Delta variant. That variant, as Dr. Sharfstein had said, is very infectious. And then compounded by this is an open, vibrant economy where arenas and mass gatherings are taking place. And then you have the waning immunity question. So when you compound all these things, we are seeing increasing number of what we call breakthrough cases. The more we have vaccinated people, the more we're going to have breakthrough cases. Just the math works that way, as Dr. Sharfstein has said. But nevertheless, we are experiencing increasing number of individuals who are fully vaccinated, who are coming down with this Delta variant. The majority of them are not very sick or don't require ICU. So the vaccine is still extremely effective against preventing progression or severe disease or even death. The experience in Massachusetts was eye-opening in a way that says healthy people who've been fully vaccinated, still within 3 months of their vaccination, can still get COVID. What we've also learned is that very few of that cohort were actually hospitalized. So the vaccine is doing its job in preventing people from getting sick or being hospitalized or requiring intensive care unit. This is what led the CDC to say, well, the vaccine is good, but we are seeing breakthrough cases, and it's time to use a multi-layer strategy like we did early in the pandemic and last fall, is in addition to the vaccination, which is still by far the most important intervention that we have, is to add the next best thing, that is masking and other PPE precautions. And so we need those two strategies at this moment as we try to kind of understand how this pandemic and how this Delta variant is playing. A lot of talk about booster vaccination right now, and who are the individuals who might benefit from booster vaccination. If you look at hospitalized patients with breakthrough, they are predominantly older and predominantly immunocompromised patients, patients who have weak immune system. So for that, I think a strategy that may start with these individuals may be one to consider in terms of booster vaccination. The country is experiencing different surges depending on where you are. As Dr. Sharfstein has mentioned, Florida is certainly the epicenter of the current surge. But we're seeing many states around the country who are seeing an increase in cases. We are in a good position in this part of the state, but we have prediction model indicating that we will see a surge in the next 2 to 4 weeks, the extent of which is still a little bit unclear. So with that, I'm going to stop and give it back to Michonne.
Thank you very much, Dr. Barberi. Just a reminder to submit your questions in the Q&A area of the Zoom. I believe it'll be at the bottom of your screen, Q&A, not in the chat area. We do have a few questions that have already been submitted, and we will get to those. Finally, last but not least, we want to welcome Director Briggs, who can provide us a local snapshot of where we are today. Thank you.
There we go. Figured out I need to unmute here before I start
Yes.
talking. So thank you, Michelle. Hopefully people can see my screen. I can just maybe add on a local perspective to what Dr. Sharfstein and Barberi have already talked about. As Dr. Sharfstein mentioned, looking at Olmsted County data specifically, cumulatively, we've had relatively low case counts, hospitalizations, and deaths compared to much of the country. So we've been very lucky here and haven't had to feel as much pain as some of the other places around the United States. Just looking here recently at this Delta variant emerging here locally, but we have started to see our epidemiological curve go back up. So I know all of our county commissioners and most people watching are familiar with an epi curve now, but you can see just over the last couple of weeks now, our 7-day rolling average number of cases has started to climb again. We had 207 cases last week, and for Dr. Sharfstein in particular, we've got about 158,000 people in this county. So the CDC metric that's being used now in these latest guidance recommendations puts us at about 118 cases per 100,000 on a weekly count, which is the metric that they're using. And for some background here, the CDC is classifying counties in this highest risk zone, the red zone, once they cross 100 cases per 100,000 weekly. But it's like 98% of the country's population, falls into that red range right now. So our case rate is increasing. We increased about 112% week over week, according to the CDC's webpage, the latest data that they've got. We do have some internal data, though, that's all not quite as data lagged. We can see with our percent positive and our case rates. It's too early to say we know for sure, but we might be seeing a little bit of slowing in the acceleration up the hill right now. But not anything that I'm comfortable really saying is happening. So CDC is also reporting us at about 5.3% positive in our test positivity rate, which is pretty low. It looks like we're testing enough people here. We do have 15 people hospitalized right now that are Olmsted County residents. Important to keep in mind with Mayo Clinic, Dr. Barbari's team is able to pull in patients potentially from around the region. And as Dr. Sharfstein mentioned, we do have lower vaccination rates in much of the surrounding community, including in northern Iowa, western Wisconsin, and a number of the counties in Minnesota surrounding us. But just from Olmsted County, we've got 15 hospitalized, and 4 of those are in the ICU right now. So we are starting to see some people show up and get quite ill from infection. We've had 104 deaths total, which again is quite a bit lower than the national and state numbers per capita. I think the key to a lot of this, you've heard both Dr. Sharfstein and Barbari mention, is vaccination. I can say it thrice as well. Vaccination is huge here. We've had a great response from the community, first in masking and distancing. And now as we've moved into vaccination, we've had over 105,000 of our residents, of the 158,000 or so, start the vaccination process. That's 68% of the entire population here in Olmsted County. I should actually forward my slides here too. If we start to break down those numbers just a little bit, 97% of people that are over the age of 65 in Olmsted County have received at least a dose of vaccine. 83% of everyone over 16 and over has received at least a dose of vaccine. And for everyone that's eligible, that's everyone 12 and older, 4 out of 5, it's 81.5% of our population has started the process. That still leaves thousands of people, in particular children under 12, are the last big group that we've got left. But we do have thousands of people still in this community that haven't been vaccinated, and we are seeing transmission really at this point driven through the unvaccinated population for the most part, with a little bit of spillover and with breakthrough cases as well. And with that, I can turn it back to you, Michelle.
Thank you once again, Dr. Sharfstein, Dr. Barbari, and Director Briggs for bringing us a full picture of COVID and Delta from the national all the way down to the local. We're so fortunate to have your expertise here with us today and our elected leaders to hear from you all. We'll now move over to questions. We currently have 9 submitted questions. I'm going to open it up to the panel. I'm not going to, as the question is asked, if just one of you self-moderate who wants to respond to the question, or if more than one of you want to respond, we'll have Travis start with those questions.
Well, thanks so much, Michonne. So to start off, we have 2 questions from City Council member Mark Bransford. I think they're related here. The first one being, what is the panelist's opinion on the COVID virus becoming endemic? And related, would you characterize a vaccinated population as being similar to a population facing the flu? So we'll just start there and open it up. Thanks so much.
Go ahead, Dr. Sharfstein.
I was going to say, please go first.
Well, I'll take a stab at this. It's increasingly clear to us that COVID is here to stay. Sometimes early in the summer, there was tremendous hope that with intense vaccination programs, that we may be able to get on top of this. With the current variant, it's clear that this is something that we're going to have to learn to live with. and use the tools that we have a bit more efficiently. It's very possible that this is becoming like the flu, where we have seasonal variations, peaks and valleys, and this will go on for a while. But I'd be interested in Dr. Sharfstein's point on this. He might have a different perspective.
So I want to take the second part of the question first. At the moment, this is much more severe than the flu. It's not really comparable, given the potential risk. And you can look at what's happening in Florida, Arkansas, Missouri, parts of Texas, because the hospitals are overwhelmed again in these areas. And they're just these alarming SOSs going out from doctors. One doctor in Louisiana saying that, you know, she can't provide the level of care that she wants to provide to her patients. And they're also, you know, seeing quite a larger number of children who are coming in both for COVID, but also for respiratory syncytial virus, which is, you know, the season with severe cases. And so what we look at is, you know, what is the population health impact? And one of the big ways of judging that is whether the healthcare system is getting stressed. And that is absolutely still an urgent danger. The goal is for COVID to be something that fades into the background, that, you know, people have a lot of protection with, and if there are little outbreaks, you can stamp them out pretty quickly. I do agree that we will be living with this for some time, but it doesn't mean we have to be living with the threat of, you know, overwhelmed emergency departments and, you know, no remaining ICU beds. I think it is totally beatable from that perspective. Certainly with vaccination and with other measures, you can keep it so that it is manageable. That's really the goal. And so I think, you know, it's important to say, like, we will be living with this, but we have control over how we're living with this, whether we're living with something that is, you know, presenting such a severe threat to our healthcare system, or we're living it and it is a moderate increase in risk for us, but very manageable.
Travis?
Yes, so if there's no further follow-up, I do see some additional questions that seem related. So next on the list is the question here. It goes, could we speak more about the waning immunity that Dr. Berbari mentioned, I think in his opening comments? But I also see a question about if some of the pushback around promoting vaccinations. If vaccinated people can become infected and can pass the infection on, will this be a lifetime fight? And the question asker states, I realize that the vaccine severely minimizes the risk of getting sick from infection, but you can still be spread.
It's a very important question. So let's look at vaccine efficacy and how much do we know? Obviously, this is something that we're still learning and trying to assessing. If you look at a number of studies that look at vaccine efficacy against the Delta variant that are out there from Israel, from our own Mayo Health system, and others, the vaccine efficacy is certainly not in the 80–90% for any infection. It's more in the 60 to 40% range. The vaccine is still highly effective in preventing severe disease or hospitalization or even intensive care unit stay. And that's what the vaccine is designed to do, is to transform a serious disease like COVID into a more manageable problem that we can live with. And I think that is really an important point to understand. You know, this is something that we're learning to understand. The science is not at the point where we could assess, you know, how an immune system works or how to measure the immune system in light of vaccination. There are some suggestions about various tools to do that, but right now we don't understand what's the best way to assess immunity against this virus after vaccination or after natural infection.
Right. We do know, though, that the vaccines are very, very effective at protecting people. And I think I would like to use an analogy maybe to build on this, which is think of a vaccine like an umbrella. and think of the number of cases in your community, like how hard it's raining outside. And if it's a really light rain, you use your umbrella, your chance of getting wet is very, very low. But if it's pouring down rain, and I realize maybe I should be using snow for Minnesota. No, but I'm going to stick with rain for the moment. If it's pouring down rain and you're going to be outside for a long time, you can have an umbrella, but you're probably going to get wet. And so in that situation, it makes sense to wear a raincoat too, and that is the equivalent of masking. So something can be very, very effective. And, you're not going to get drenched. You're not going to get severely ill if you've got your umbrella, but you could get wet. You could get mildly ill. And so, not getting vaccinated is like going outside in a rainstorm, without an umbrella. I mean, you're going to get wet. People who are not vaccinated are very likely to get COVID now. And so the idea is that just because it's not perfect, just, you don't go like, well, I'm not going to take my umbrella because it absolutely makes no difference because I might get a little wet if I go outside. Nobody thinks like that. You carry your umbrella. And if you're worried, you also put on a raincoat. But that's what people should do. If there's a lot of virus in a community or a higher risk, you get vaccinated and you wear your mask. But I see all the questions about like, well, I mean, I could get still sick, so why should I bother getting vaccinated or wearing a mask? I mean, you could get much, much sicker if you don't get vaccinated or wear a mask. And I think the analogy to the umbrella and the raincoat might help. Those same people certainly are not, just decided that they're going to go out and get drenched every time they go out.
I can maybe just add too, from a local perspective, we're seeing the cases on the ground. Our team here is interviewing everyone that is lab confirmed with COVID. And we've seen deaths, we've seen severe cases, we've seen families lose loved ones for the last year and a half here. That calculus changed when vaccine became available. And we can see that in the work that we're doing here on the ground. In the handful of breakthrough cases that we've seen here locally in Olmsted County, when we interview those people, for the most part, what they tell us is that they had a headache for a day, or a 99-degree temp for a day or two, or slept 12 hours, and that was weird. They're talking about cold symptoms. And to me, it feels like jump-starting the immune system from zero to immune is a big step that people have to take. We can do that through vaccination or through natural infection. Tweaking the immune system after we've got some immunity so that we start developing cross-protective immunity against variants as they're emerging, I'm guessing is where we're starting to go as this potentially could become endemic. That's hypothesizing a bit there because we don't really know what's going to happen, but I think there is some very encouraging both large-scale data and local stories here that are showing us that vaccine is protective against severe disease and death, and it is hugely important in the battle that we're fighting.
Yeah, I mean, I want to reemphasize that none of the treatment in medicine that we deploy is 100%. If you treat somebody for high blood pressure, that's not 100% protective. It reduces a chance of complications, but it's not 100% protective. Every medicine that we take has very similar, where we know the benefits outweigh the risk. And this vaccine is no exception. There are some breakthrough. We are learning, about the boosters and other things, but to the most extent, it transformed a deadly disease into a more manageable, mild illness in most patients.
All right, if it's okay, I'm gonna group a couple of these questions about masks in here to next. So that goes. I think we had addressed the one about the need to vaccine for masks and a vaccine. But the next thing here would be, would masking only where children are present be useful? Or we're hearing from people who say that if the Delta variant is more about the aerosols, and cloth masks might not protect related to that are there certain types of masks that would be recommended, such as will cloth masks 20% effective against Delta be efficacious, especially for children under the age of 12? So I'm just going to group those together and see if there's any response from the panelists. Thank you.
Would you like me to take this one? So what we know about the Delta is that you can have breakthrough, and we know also that vaccinated individuals, although they may not get sick themselves a lot, they can still transmit it. And the infectivity of this virus is higher than the previous variants. What we also know is that the predominant way of transmission is still droplets. These are larger particles that are not going to land beyond 3 to 6 feet from the source. So if you take all these together, a masking strategy is the way to go. A standard mask, a multi-layered cloth mask that's well fitted, or a surgical mask in the medical environment in most instances is all what you need. What we also know is that mask only works if everybody's wearing it. And the best scenario is the source and the exposed are wearing a mask. That's really the ideal scenario where mask works the most. So we have to use the mask in addition to the vaccine, because vaccinated can still transmit the virus, especially with the Delta strain. And children under 12 are in that category because we cannot currently vaccinate them because there's, it hasn't been authorized in that environment. And wearing a mask in that situation may be advisable.
All right, thank you so much. Were there any responses from the panelists?
I thought that was a great answer.
Thank you so much.
I do think that the quality of the mask, depends on the environment, and there will be, I expect, recommendations for which kinds of masks a little bit more for which scenarios. For me, if I'm with my parents, they're vaccinated, I know where they've been, I know where I've been, I'm not wearing a mask. If I'm with a larger group of people, maybe 10 to 20 people, we're, somewhat distanced, but we're wearing masks indoors. Our school now has an indoor mask requirement. I might wear a cloth mask. If I'm going to the grocery store where, there are people who might not be vaccinated around, and I really don't know what the environment's like, I'll wear a KN95. So, I'm kind of, for myself, depending on the situation, deciding on the kind of mask that I might wear. But I'm just giving that as an example. I do think that we will have more information as we see what happens, for example, as the schools open. The schools are opening in the South early. I think this will be something that is really important to look at, and the quality of the mask may turn into a bigger issue as we see how Delta behaves in schools.
I'm going to jump in here. There's a lot of questions. Travis and I are going to toss them back and forth. So the next question I'm going to ask, can you please talk about what we truly know and what does the data say about antibodies in vaccinated people versus those that have had it and recovered? If we are talking about measuring total population protected, why don't we count those that have had it and recovered?
So what we know is that the antibody response, and more importantly than the antibody response, like what do we really care about is whether people get sick again. That's what we care about. That is immunity. Antibodies is one possible way to measure immunity, but it doesn't really measure all of immunity. What we really care about is people and their risk of getting sick again. And the immune response is quite variable when people get sick. So if I get sick and you get sick, it may be that one of us has a very strong immune response that will protect us for quite a while, but the other person could be quite susceptible. And in fact, in some cases might get sicker the second time. And there's data, for example, from Brazil that I've seen that people who had mild illness sometimes have the more severe illness the second time. If you look at India for Delta, 50% of India was exposed to the regular coronavirus before the Delta wave, 50%, and the country got wiped out by Delta. Many people who had been exposed to coronavirus then got the Delta infection. And so for that reason, it's very hard to know who might have been infected actually has durable immunity. And so you don't count them because you don't know what the actual level of, you don't count them as equivalent to being vaccinated. For the vaccinated population, there is very good data on durable immunity for a large number of people. And that kind of data does not exist because there's such a varied response to infection. So that would be my reason. And I would tell somebody who's been infected, you don't know. I would say, are you a gambler? Are you a risk taker? Because I can't tell you. It's like putting a ball on the roulette wheel, the level of protection that you have. Maybe it's good, maybe it's not. Do you feel lucky? And if they feel lucky, then maybe they won't get vaccinated, but they could really pay for that bet. And a far safer decision is to go ahead and get vaccinated after you've been sick.
Would anyone else like to comment on that?
No, I think that's well stated. Thank you.
All right, thank you.
Maybe one more thing to add I see that was Chief Franklin that added to that. We also know that there's a piece of the population that's getting asymptomatically infected. And so when we're talking about community-wide immunity, we do something called serosurveys where we go and randomly try to get a feel for what percentage of the population has antibodies. But that, as Dr. Sharfstein mentioned, still doesn't really capture immunity. So when we're trying to get a good view of what's going on overall, we can say so like 8.5% of our population has been confirmed with COVID. We've seen very few reinfections, in the cases that we're counting, but trying to estimate the amount of asymptomatic infection out there is a lot more challenging. And so we can measure the people vaccinated in the same way and feel comfortable that we've got a high percentage of people vaccinated and most of them are well protected. But as I think all three of us have mentioned now, in medicine and in science, nothing is ever 100%.
All right. Thank you all for that response. Travis, do you have the next question?
Yeah, I kind of have a group here around decision-making and data. So one question asks, have case rates been separated by vaccinated and unvaccinated in Olmsted? Or what percentage of all Rochester residents are vaccinated? I think a good summary here might be, as the pandemic continues, what is the criteria about when to mask and we can stop? Is it an infection rate, hospitalization rate, mortality? And I think that's the questions around numbers. Oh, another one here that I slightly forgot, which would be the value of masking as a way to reduce hospitalization over a 6-month period. So these are the types of questions that we're looking at. How do we read the data to make decisions?
Yeah, I could maybe start by talking about local surveillance and what we're seeing, but that really goes up to the CDC putting out federal guidelines that as they get to the state and the local level, we can apply those and use those as a baseline to start from. And so what the CDC's attempted to do with the guidance that they put out now is to classify risk. And so Olmsted County, like most counties in the nation right now, are in this high risk area according to a lot of really well-respected and wise national leaders in virology and immunology and infectious disease, developing those guidance documents. I think locally here, though, we could say we're in an area where the CDC is recommending that we use masks. We can also see that we got high vaccination rates. We also know just from experience, we had a normal summer here, like very few places across the country did, where we've been watching at the local health department for cases to pop up around outdoor venues and around different things like that. I think this is shifting with the Delta variant emerging, but we had outdoor concerts and things like that here when we had very low viral activity, and we didn't link cases to those sorts of events. And so if we want to look for a hard number with case rate, we can look to that CDC guidance at being over 100 cases per 100,000 population on a weekly scale. But we want to apply that then locally to our understanding as to our vaccinated population and how all that works together. I don't know, Dr. Sharpstein, if you want to talk about kind of vaccination in a larger context or anything like that. I know what we see here is very localized, and what we see here is very different than what Louisiana is seeing right now. And that to me is kind of what I'm trying to talk to this group about a little bit is if we were to get to that point, we get more and more aggressive, I think, in our mitigation strategies, but we haven't ever been where Louisiana has been 2 or 3 or 4 times now with some of the case rates that they've had down in those areas.
Yeah, I mean, I think that's an extremely good point that, you're for multiple reasons in a much better place. And, I'm looking at your county vaccination rate, though, it's still at about 61%. Is that right for both shots?
A little bit of data lag. Overall population, we're at about 67% according to our local data. That should be.
Yeah. Yeah, I mean, I think that, the models that are done, really are looking at like trying to get to 80, and to be in a much better place for the Delta variant. So, I think you're right that you can use the case count to make decisions about what kind of recommendations. It's sort of like, saying you don't need to wear a raincoat because it's unlikely to rain or it'll be a light rain or something like that. I think that totally is fine. But I do think that you're not in the clear, you're not likely to be in the clear. It's quite likely you'll see a surge in cases unless you can get the vaccination rate higher, which, I know that you're in the business of doing.
Yeah, the vaccination part is huge. I think with that, right, with the umbrella analogy too, case rate, it's hard to have one metric to really understand this. We want to be watching hospitalizations, and in particular, the percent positive is a big deal too. With that umbrella analogy, you could say you can close your eyes when you're outside too, and it doesn't mean the rain stops hitting you. And right. So we've got places in the country right now with 40+% positivity rates in the testing that they're doing, which is saying you're not really looking out there with test confirmation for cases and interrupting transmission. And so that's something that I want to keep an eye on is 5%. We've been lower than that, but if that starts rising, that starts telling us that the virus is running faster than we are and we need to speed up.
I think the way you're looking at this makes total sense, and it basically adds up. I don't know, I did not look to see whether you have kind of like your yellow, green, orange, red kind of clear system, but what I found helpful in different places is if there are, you basically are looking at the case rate, the percent positive, some really core statistics, and basically making a judgment based on that as to the level of risk overall. And then that can drive certain activities like recommendations around masking. I just think that it's just important to keep in mind that the history of this pandemic is the history of people in every corner of the globe coming up with reasons why big problems can't happen in their area. It was like, this is a problem in China, it's not going to come to the United States. It's a problem in Italy, it's not going to come to the United States. It's a problem in New York, it's not going to come to Los Angeles. And, everybody can constantly convince themselves that their area is different. And you just have to resist that and assume that it could come and, really kick the tires of your argument of, why you're relatively protected. And I think it's probably vaccination that's the biggest protection for you.
That reminds me of, it's a concept in public health overall. I think that we can talk about data all day long. And as data nerds, which I think all three of us are, we could chat about that till the sun goes down. Lived experience is a different thing. And I think we're hearing about that in places that are being hit hard, that this person didn't think that COVID was real, or that it wouldn't hit them or infect their spouse or their mother.
Right. Or I got COVID, so I think I'm totally fine now.
Yep.
And it's very, very sad when it's just terrible when people in that situation wind up finding themselves sick.
I just read a story the other day about patients in southern states or states with low vaccination rates pleading with their attending physician in the emergency room to get vaccinated and being told it's too late for vaccine for you. That's something, this is a vaccine preventable disease now. We can stop these deaths if people get vaccinated before they get exposed.
And, all the people who are listening to this, I'm sure as community leaders have such an important role to send that message.
Thank you. Dr. Berbari, you haven't responded. Do you have anything else to add?
No, I think the message here is that we need to vaccinate. We know that with the Delta variant, the herd immunity concept has been pushed to its limit because it's, the formula to get to that is dependent on how infectious is a virus. And, the original estimates with the previous variants were 70–80%. Now it's in excess of 80%, and some people are saying in 90%. So we have to vaccinate as many people as we can. There is a ongoing study for children between the age of 5 and 12 that will go in front of the FDA. Hopefully that will get approved under emergency use. And then we have a bigger N to vaccinate or potentially eligible for vaccination.
Thank you. I do have a statement of clarification on this last question. 80% of all vaccinated, 80% of all, including kids under 12.
So,
Just
go
to
ahead.
clarify that statistic.
Yeah, I think it's probably referring to the goal that you referred to, Dr. Sharfstein.
Yeah, the goal is of eligible people at this point.
80% of eligible.
That is what has been modeled.
Okay.
And so for reference, what MDH, the Minnesota Department of Health, is listing for us specific to Olmsted County now with 12 plus, it's 105,118 has started vaccination. That's 81.5% of our population has started vaccination in 12 plus, and 77.8% of our population has completed the vaccination series.
Thank you for that clarification. Oh, my response was bingo. We have 9 minutes, and I'm going to shift to a couple student-related questions. The first part of it, how soon do you anticipate an emergency approval for vaccines for under 12-year-olds will be given? I'll let you answer that. If just one of you want to respond, a couple of you want to respond, and then a follow-up on a couple of student-related education questions.
So let me just say that there are a few steps before FDA is going to, give authorization. The first is they really have to look carefully at the clinical data. And FDA has been very, stepwise in this. They take one question at a time, they look at the data, and they explain their decisions. We don't know the data yet for 5 to 12. So if the data is good for 5 to 12, and I understand they are asking for some more data, it probably will be evaluated sometime in early fall, maybe late September, sometime in October. That would be my expectation. Although hopefully they would explain if that timeline, which most people expect, would change. So I don't think it'll be around for the start of the school year. It might be an issue for later this fall.
If no one else wants to respond, a couple follow-up questions on that. Last year, the Rochester Public Schools provided 1 mask for each student and each teacher, and they kept a supply of masks on hand. I believe those were blue surgical masks. Should the district be ordering KN95 masks instead?
I think you might find a divergent answer on this one. What we know is that masks are as good as we're compliant with. And some of the N95 masks, especially the K ones, have not been heavily standardized. They are predominantly used in a healthcare setting, in areas where we're producing aerosol following a surgical procedure or an airway procedure. And our stance, at least for now, is to stick with that scheme as to where, anything outside the healthcare setting where aerosol is not an issue is to stick with a multi-layered, well-fitted cloth mask or a surgical mask that's well-fitted. I want to ask you, so you gave each student a mask. How often was that? Is that just one time, or what's the frequency of changing that mask? Or
We'll wait for a response from the person who asked the question.
And maybe I can add in to KN95s and N95 masks. Those are really respirators and rely on fit testing and proper use. And I remember when I had to get fitted for these things. You've got to find the right one that matches your face and things like that, and then get tested to see that you're not passing air in and out of this. And so with children in particular, finding a mask that fits, fit testing is not going to be happening in that population. And so there are a number of challenges to really get the full bang for your buck. I think if you're looking at N95 respirators, if you could do it and do it successfully, find the mask, get them tested, you are going to potentially protect the individuals at a high level, but that's a lot easier said than done, I think.
Yeah, I don't want to disagree. And I'm not disagreeing. I guess what I would say is that the recommendations, what you're hearing, totally makes sense to me. I'm just putting a note out that we're learning about this new virus, the Delta variant, and we're going to see what happens when kids get together. And in places where, they are wearing surgical masks or well-done cloth masks, if there's a lot of spread in those settings, a question that will come up will be, should kids be wearing different kinds of masks? And not, not all of them need fit testing, the more advanced masks, but they don't, the ones that provide the highest level of protection do, but I think that's very unlikely for schools, but probably impossible for schools. But I do think that this question of mask quality may become more of an issue if there are problems in schools even after they open with the regular precautions. And I think in Minnesota, you'll have a chance to see what happens in other places and learn from that. It's just the other kind of fact about this pandemic has been that things have changed and we just have to be prepared. So I'm just saying this is a potential area to watch.
Director Briggs?
I think Dr. Sharfstein covered it there.
All right, thank you. 3 minutes, the final question. We've had several questions like this, and it is for each one of you to respond. Would you recommend a mask mandate for Rochester and or Olmsted County?
Sure. We look up. I think the CDC guidelines are pretty helpful here. And so I would follow the CDC guidelines. I don't know whether you've exactly hit the threshold, but if you do hit the threshold, I would say definitely yes. If you haven't hit the threshold, it's a question of the Midwestern risk tolerance that you guys want to apply. But I think that if you're at that level, I think the CDC's rationale is pretty strong for that.
I think risk tolerance is a really important phrase there, because we can see the CDC's guidance and we are just barely over that line into the red at 118. So we've been probably 2 weeks over the line now where CDC is saying people should be masked indoors. But there's also, I saw somebody mentioned something about COVID fatigue with mask use, particularly in people that are vaccinated and things like that. We've got enforcement questions and things like that. And so I think all three of us, I'm guessing, correct me if I'm wrong, but as public health professionals and medical professionals, we want everybody to be vaccinated and think it would be a good idea for everybody to have a mask on when we see transmission happening locally. However, when we add that viewpoint into the real world, there becomes these questions about, will people do it if we ask them to, and some of those other things that require some level of debate or application to a local population for elected officials and others to be able to make those sorts of decisions.
Dr. Berbari?
Yeah, I mean, I think these are all fair points. Any intervention that is done is going to have a pros and cons. What we've learned through this crisis since it started a year and a half ago or more is that half solutions don't work. This is a very difficult virus. It's highly infectious, and it has a certain level of mortality and a certain level of asymptomatic spread. So it's kind of the right balance. And any halfway or regional solutions or kind of education solutions that may not get you to a very high level of compliance, they just don't work. We have numerous examples in Europe, across all the world, that these things don't work. And I would argue that you have to force. Education can get you that far, and you got to have a different mechanism. Given the urgency and how this has impacted our life and our country in very profound ways. So traditional ways or softer ways may not be enough. That's my concern.
Thank you, gentlemen. Thank you to our audience for the great questions. We do have some unanswered questions that we will do our follow up with, and hopefully our panelists here will assist with that. I want to thank, it is 1 o'clock, and I want to honor your time. I want to thank Mayor Norton for coordinating this. I want to thank our panelists, our expert panelists, for taking the time today, for your willingness to help with sharing information to our elected leaders here in Rochester. Thank you very much. Finally, I want to thank our leadership, our county commissioners, our city council, and our school board members for their leadership in our community during this time. So thank you very much, all of you. Everyone, stay well and be well. Thank you.
Thank you.
Waiting.